Okay, so I think we're live for the last session of today. We've had a fantastic morning. A warm welcome to anyone who's joining us, the attendees who have joined us. Good evening, I guess, for Singapore local time. Good afternoon for anyone else who's left of that. And it's a very early start for us here in London, and an even earlier start for some of the panelists. Ryan Tokarz from the Centers of Disease Control, Ethiopia. I know, Ryan, that you're based out Washington at the moment, so thank you for joining us for that. This particular session that we've just had quite a few sessions looking at the immunological landscape and impact to treatment strategies, also to diagnostics, new horizons in terms of novel drug targets and potential new therapeutics. What was quite evident in all of those sessions is the need to progress through partnership. One of the areas we're very, very interested in terms of looking at in terms of partnerships and bringing that asset, as it were, into the equation is the actual community itself. And so we thought we'd have a very, we'd look at that through the optic of vector control. And this particular session is called Tackling and Preventing Dengue Fever, the Road to Integrating Vector Control and Surveillance into Communities. A bit of a long title, but it's trying to encompass everything that we're going to be talking about. My name, if you've just joined this session now, is Kamran Rafiq. I am the co-founder and communications director at the International Society for Neglected Tropical Diseases. We've been spearheading a global campaign asking for an official ratification by the WHO and UN for a World Dengue Day. And as part of that, we've set up a dengue advisory group, and I'm very honored today and delighted to have this panel with members of our dengue advisory group, Dr. Ryan Tokarz, from the Global Health Fellows at the Ethiopian Centers for Disease Control. We had a session with Ryan a few weeks ago when he was based out in Addis Ababa, and for today he's joining us all the way from Washington in the US. So hi there, Ryan. We've also got Dr. Soumya Iqtidar, the chairperson for the Government of Pakistan's Dengue Expert Advisory Group, as well as our own dengue advisory group, but she's spearheading the kind of dengue response, as it were, in Pakistan. A very interesting presentation, I'm sure, in terms of their approaches and what they're doing in terms of a tracking system that they've got, bringing those communities together. We've also got, joining us on behalf of Bayer Vector Control, who just joined our dengue advisory group as well. Talking on behalf of them is Dr. Mitra Sadatan Ilahi from the University of Lyon in France. I hope you're having as good as weather as we are, Mitra, here in London today. It's a fantastic day on a Sunday. I think this is going to be a very interesting session. We will have presentations and then a Q&A at the end. I would ask the wonderful attendees who are here en masse, if they could, feel free to send in your questions. We will channel those into the Q&A. I'd also ask you in the chat boxes to put your name, country, and affiliation so that we can reference that, and it gives a good kind of feel to which countries are in and out. We've had over 2,000 registrations apparently from the support team at ADVA. They're letting us know that, approaching 2,000. We have a global petition that's live at the moment. We've got approaching 29, just shy of 29,000 signatures. I'd urge everyone who's attending, listening, watching to sign that. It's going to increase the pressure head in terms of getting this World Dengue Day out and about. And it really underlines the global nature of this disease. We said vector control. You would have heard in some of the earlier slides that in the 1970s, and we often hear this almost become a platitude, that there were a handful of countries presenting with dengue in the 1970s, 9 or 10 countries. The situation now is that we have over 100, approaching 120 countries with dengue. Underlying that is the spread of the vector. One of the major concerns of that, and major drivers of that, is the spread of the actual vector. And in some circles of thought, that kind of the explosive nature of dengue was really underpinned by the lowering in global vector control capacity that occurred in the 1970s onwards, which then less vector control activity, more spread of the vector, hence more exposure to the disease. And we're definitely seeing, as you've heard in the earlier presentations throughout the morning, increasing incidence rates, increasing hospitalizations, between 400 and 500,000 a year. And so vector control has a huge part to play moving forward. It always has done, but it's really been exemplified now. There are issues with COVID restrictions, which we can explore in the kind of Q&A. But there's a central role for the community to play within this. At the end of the day, mosquitoes bite people. They are part of the actual equation. Those individuals form those communities, and they are an asset in terms of vector control, certainly. I think we'll allude to some of that, both in the presentations and in the Q&A. I think that's enough for me, and I think we'll hand over the floor to Dr. Ryan Tokarz from the Ethiopian Centers for Disease Control. Ryan, over to you for your presentation.
Thank you, Cameron. Thank you. And good morning, good afternoon, good evening, wherever everyone is in the world. I'm quite honored to be here with you all and happy to discuss a bit about Ethiopia and its dengue surveillance. So as Cameron so greatly introduced me, my name is Dr. Ryan Tokarz. I work with the Center for Disease Control, the Ethiopian office, based out of Addis Ababa, Ethiopia. I'm currently in the US right now, but continue to support them from afar. Anyway, I will get started shortly, and I appreciate everyone's attention. Okay, so yeah, so dengue in Ethiopia. This presentation was going to be centered really on the integrated dengue surveillance system in the country. This is kind of in its infancy stages and just beginning. So I thought I'd give more of a comprehensive idea of what's happening, what the surveillance system is doing, different response techniques that are in place now, and the ways forward along the way. As otherwise it would be somewhat short, as it's, like I said, it's just beginning. As we'll get into here, dengue is quite new in Ethiopia. So just a bit of outline of what I'll go over, kind of history within the country, the current status, what's going on right now as a result of dengue. The surveillance system in place, the kind of typical response control activities, the gaps, and then progress going forward. So in 2013 is when dengue was first detected in Ethiopia. And as you can see, it was quite an outbreak. It was about greater than 12,000 cases. And this occurred in Dawa, which is in the eastern portion of the country. Just from the kind of the dynamics of this, it's more than likely that the pathogen was in the country prior to this. And it may have taken just such a large outbreak, such as this one in 2013, to really kind of put it on the stage. This portion of the country is a bit resource limited in terms of its laboratory capacity. And so I think we would have needed a good amount of cases to present for it to get picked up. So 2013 is when it was first detected. And from there, it was once there was awareness and further seeking and surveillance occurred, we started to find in other places and other outbreaks were popping up relatively commonly. In 2014, multiple outbreaks occurred, once again in Dawa, and then these various other towns, Godi Town and Adar. Both of these are also in the eastern portion of the country, and all three of these are in a fairly arid desert type region, which is pretty interesting in terms of dengue. And I kind of get into it more, but they seem to be focusing themselves in this area, which presents actually a decent amount of problem based on a lot of the behavior and cultural components of the population of that area. And through 2016, 2017, there was a serological study to look at dengue throughout the country, see where it might actually be. From there, they were able to identify it far off areas such as the Tigray region, which is kind of up where it was found here is actually kind of in the northwest of the country. and then the Amhara region, which is also in the western portion of the country. So it's kind of just to give us a quick idea that this may be more widespread than we thought. Of course, it's a serological study, so in theory, the populations who tested positive could have picked it up anywhere, but it is at least a data point that it may be worthwhile to look in a much more broad area. It has since become established in Dire Dawa and Godi Town, which are two of the areas that happened in 2014. We're having yearly outbreaks in these towns as well as the surrounding areas. So it's definitely something that's here to stay, and it's a new emerging disease that is something of concern in the country. So here's just a quick visual of all these different towns I was talking about. If you're not too familiar with the geography of Ethiopia, I would just be throwing out a bunch of names. So this is where everything's located. Godi Town, Kabra Adar, and Dire Dawa. Those are all the arid type areas. If you look on the other side of the country, Humera and Matima, those are the two from the serological study. But the real important component here is how widespread these are, showing that this is more than likely a countrywide issue and something that needs to really be focused on. Okay, so our current status, 2020 was kind of an outlier, as we all know, for many, many, many reasons. So there was a bit of a resource pause in terms of real strong surveillance, though issues were addressed, but not too much was observed in terms of dengue, and I believe COVID and the resources that were pulled for that probably had something to do with it. But however, most recently in 2021, there were two fairly solid outbreaks in these areas called Dolo Odo and Warder. Those are quite close to areas we saw before. I'll show you a map that gives you a little more context on that. But these weren't as big as the 12,000 case outbreak. The last numbers I saw were 160 cases and then 47, I believe, that were suspected. These are no longer ongoing, but they did occur, and it kind of shows that even despite the resources directed at COVID, that there's still dengue surveillance going on and an understanding of its location in the country. And very positively, as of right now, we don't have any ongoing outbreaks anywhere in Ethiopia. At least that's currently known. And here's just the addition of these two new areas, Dolo and Warder. You can see where they're on the same general area as Godi and Kabra Adar. This is the Somali region of Ethiopia. Okay, so surveillance and kind of what the key meat of this is, there's actually currently no continuous vector surveillance going on in the country. Malaria being the outlier there. There's strong malaria surveillance, and there's been a focus on that, as that disease has been a problem for many years, and it has been had some very positive effects. So we're hoping that dengue has similar outcomes. But there is plans to do this. This is something else that I believe that dengue was affected by COVID with. These plans were kind of put on hold, or so I understand, as a result of a lot of the different human and other resources being directed to COVID. And then there is also surveillance that does exist at specific facilities, meaning that if a regional hospital or a healthcare center or something is able to identify a case, they can move it up the case reporting ladder, which usually goes from the lowest kind of community level up to the regions, up to eventually directed towards the national level. So in that sense, surveillance is occurring, but there's no active surveillance going on right now. And hopefully that is something that is in the cards in the upcoming months or years. There is, however, a trained rapid response team. So this is a fairly new development. These are basically arboviral-based team that's based at Addis at the national level that responds to two different outbreaks, dengue being one, when they are identified. So this is a positive development. They go out, assess the issue, implement control measures, do various forms of active and passive case search, seeing what might be affecting the issue. Do a lot of field epidemiological techniques to identify what may be causing the issue, and then address them like that. So this is one of the new developments that's trending positively towards dengue. There's also other possibilities that could prove beneficial down the line. There's AFI sentinel surveillance projects underway or in the works. This is an acute febrile illness surveillance program, which basically looks at people that have unknown acute febrile illnesses, and will test them for an array of different pathogens to see what they may be suffering from. So there's various university labs, private labs, and things like that that are on board. So hopefully these projects can get up and running and give us a stronger idea of where in the country some of these infections may be, where you're showing more of the, or shall we say, less of the hemorrhagic component of dengue and more of the standard infection. Because at this point, it's often not identified until you see a hemorrhagic type of patient. Otherwise, it's just such a nondescript amount of symptoms that it's often overlooked. But these AFI projects are planned to include many key arboviruses, dengue being one of them, chikungunya, Zika, things like that. And then the ability to use real-time PCR to identify dengue is there. They often use a triplex, which has dengue, chikungunya, and Zika on there to identify co-infections or single infections, and that capacity is at the national level. And there's been multiple works done on that. And actually, the paper that we discussed, myself and my colleague Mulugeta recently for the Society for Neglected Tropical Diseases involved this particular technique to identify. I should also state on that sense, it's a bit unfortunate that Mulugeta is unable to join us today. He's had some family issues and he's there supporting his family, but he has a real strong, deep intimate knowledge of what's happening on a lot of these surveillance projects and what's happening in terms of infections throughout the country, as his position within the government health system is kind of exposes him to much more. Oftentimes at the CDC, we're there as kind of technical support or kind of capacity building. So often a lot of these issues will be dealt with internally and we'll help when needed. So it's a bit unfortunate he's not here to really dive deep into a lot of the specifics, but he did help me develop this slideshow. So at least he's here in spirit, and yeah, we are missing him. But anyway, so once there's an issue identified, then there's the response and the control that's activated. This is pretty strongly entomological focus, of course, involving dengue. They're often looking at these different specific larval indices, the Brucho index being the most important, and that's just looking at the kind of the number of homes per 100 that are infested with larvae. The house index and the container index are looking kind of percentage of houses or percentage of containers within those houses that are infested with larvae. But the Brucho index is really the one that helps identify the severity of the outbreak, at least within these initial response activities. There's often adult surveillance, which involves aspirating adults that are flying around or doing pyethon spray counts within homes. And then there's an identification process that goes on to see what vectors may be involved in this process. You know, as there's a variety of vectors that may transmit dengue in Ethiopia. I think the main ones that have been identified are Aedes africanus and Aedes aegypti, but they do function differently. So knowing what the dominant species is will help tailor the actual entomological control. So there's a good portion of that kind of is there to confirm dengue exists and then to confirm the actual vector that's occurring and causing these issues. And then there's a big push towards engaging the communities. A lot of this is doing with environmental manipulation, pouring out water, storage, cleaning up different areas that may be conducive to things like Aedes aegypti ovipositing. And then there's lots of education going on because this is such a new pathogen in the country, and especially in a lot of these areas that are somewhat remote. There's not much knowledge about dengue. It hasn't happened, or it hasn't been around for many, many years. So the institutional knowledge is low. So educating the populations, and then sometimes even educating the different health sectors on how to best deal with this medically as well as otherwise. So there's a big engagement component of this, which tends to be quite beneficial down the road. As well, I guess maybe a good time to talk about this. So the interesting thing about the Somali region, as I said earlier, is it's quite arid. It's more or less a desert, and so there's a lot of different cultural practices that are interestingly protective or conducive to dengue infection that isn't as common in other places in the world. So this community engagement has really helped understand that. I know in the paper we discussed a month or so back, there's an interesting component where bed nets actually were shown to provide protection from dengue. And that's because it was just so hot in these areas that during the day, most people would sleep. And of course, that's when these ADs are fairly active, but they would sleep under their bed nets and actually get protection. Then they'd work in the cooler hours of the day. So a lot of these community engagement projects have helped identify things like that, which would be kind of atypical control measures, but that are actually beneficial towards dengue based on the specific environment in which it's occurring. And then in actual control, there's a focus, of course, also on vector control. So the nets, which I just discussed a bit, often distributing, there you go, repellents, fumigating highly infested houses. Source reduction is a big one in terms of Aedes aegypti. And there's been discussions for things like larvicide and other different approaches, but the other ones are the main approaches. There's a lot of public health communication that went through the educational thing we talked about before, and then healthcare case management training also kind of all tied up in the educational component. So it's really kind of a combination of vector control and education, and really tying in those community members who really understand the community itself, and then using the kind of institutional knowledge, entomological knowledge to tie in what may be happening with the vector with what may be happening in that specific community. So in terms of gaps, so I mean, there's definitely some gaps, especially the most kind of glaring one being that there's no consistent vector surveillance. This is really kind of preventing any sort of early warning or early response. And I think this is something that we have identified and that the country is hoping to address in the upcoming months. But this is kind of the biggest gap. And I mean, they do have the response team, which is quite beneficial, but having that response team respond earlier will only prove more beneficial. So this is something down the line we're looking to address. And then there's resource limitations that are often an issue. A lot of these areas are quite remote. So the laboratories out there may not be as well supplied, may not have the proper equipment, things like that. In some of these regions, rapid tests are still something we're looking to possibly involve. And then, of course, treatment things in terms of pesticides and all that. Adulticide and possible larvicides are all expensive and kind of have to be strategically based. And so that kind of gets to another gap of the actual distribution, which I'll get into in a bit. But to understand where those things need to go, you need to understand exactly where the issues may be. And then there is also this kind of the lack of the IDSR reporting requirements for dengue. This looks like it may be changing down the line as well. But as for now, it's not a required reporter disease. So it's typically something that comes from the healthcare systems up. So there's various other difficulties that could cause issues with dengue in the area. Unplanned urbanization is a big one. A lot of these towns we're talking about are quickly urbanized. So there's sanitation issues, which of course we all know are quite conducive to Aedes aegypti. The movement dynamics are quite difficult. This is one of the specific regional issues for a couple of these places that there's a lot of populations that are quite nomadic and pastoralist. They pass through with their livestock, they stay for a certain amount of time and then they move on. I know in the paper that we presented, we had, I believe 14 or 15 households that were of this group that were unable to be followed up because they'd moved on. But often these people are infected themselves, or their water sources are moving with them and they're moving things around. So exactly where these populations are moving is not really well known. So the distribution and the movements of the vectors along with these people is something that can be quite beneficial to fully understand. But is a difficult population because it's hard to get a kind of good grasp because they're constantly on the move and certainly not terribly tied in terms of technology or anything like that. So that makes it a bit tricky to understand the true distribution of the vectors within the country. And I think that's probably going to be an issue that will continue down the line. Probably a more of a approach would be a social approach on that end to really kind of begin to understand the movement dynamics. But that's something that is quite interesting to me personally. It's also, there's issues with the remoteness. I discussed this a couple of times, but some of these areas are very hard to get to. And so it's very hard to get supplies there. And it's also often very hard to get samples and supplies out of there. If the laboratory capacity isn't there, they often will send it to the national lab in the capital. But because of the remoteness, it's hard to transport these. Oftentimes, things like blood serum need to be at certain temperatures that's difficult to do over long periods of time. So that's an issue. And then this is, of course, a new disease of concern. So the understanding, as it is discussed earlier, is still not fully widespread. So something like that is causing a bit of a difficulty as well. All of these, however, have the potential to be rectified. So there's at least hope. And more continuing down the hope path, we have strengths. There's plenty of strengths, and the country and the arbobio groups have made a lot of great strides since my few years in Ethiopia. There's a public health entomology team. There's a national one. It's quite strong. I've worked with them, and they're a great group. And then some of the regions, not all of them, but some of the regions have their own entomology teams. And then there's also universities that have strong entomology backgrounds that have the capacity to help. We do have that rapid response team that's able to respond to any of these outbreaks once they're identified. There's a very, as I touched on, there's very strong entomological capacity, epidemiological capacity. They do a great job of understanding the actual components, both kind of entomologically and anthropologically, looking kind of the human behavior practices and how they may impact disease transmission and vector distribution. And then they're very good at involving a community in this process. The national testing capacity is quite good in terms of identifying these. And then there's strong partnerships with groups such as CDC and others, and a strong commitment to address these issues. So all of this is pointing in the positive direction. So kind of with all this moving forward, there is plans to implement this high risk, or surveillance in these high risk areas. As I touched on before, hopefully these will be happening soon, and there's not too much more of a delay as a result of our current issues. Then also there's an early warning and surveillance system that is planned to be enhanced, perhaps enhance these detection capacities in the regional labs more or less. Because the national lab detection capacity is quite good. And then develop things like technical working groups that could be staffed by people from all over the country that could kind of discuss dengue in the context of their general areas. So just the key takeaways to wrap it all up. This is an emerging, super important disease in Ethiopia. There's strong awareness and support for it. And the more common it's becoming, the more people are beginning to understand the importance of this. So the more awareness and support I think we can do and give it, the better it will benefit everyone. The distribution is likely underestimated. The amount of dengue, the impact of it, where it's at. I know I discussed this kind of at length, but we're really kind of unsure exactly where this is and who exactly has it and how much of an actual economic and health impact it's having on the country. So that's something to look forward down the line. The country's quite aware of this, however, and addressing it, which is positive. But there's quite a number of improvements that still can be made on the vector control side of things, with education, with resources, with laboratory, all of that. But in the end, I think Ethiopia is moving in the right direction, and I'm quite confident they'll get there. But the continued awareness and support, of course, is always needed. Thank you all. Thank you for your time.
So thank you very, very much for that, Ryan. A wonderful presentation, giving the real kind of look at where Ethiopia is and your moves in terms of pushing for an integrated disease surveillance system at national level, some of the kind of issues that you're focusing on. You alluded to your colleague Mulugeta Gutu. We were honored to have Ryan and Mulugeta open up the paper that Ryan mentioned. And for us, it was very interesting because it was reframing. Ryan was from the CDC Ethiopia, obviously, as we've mentioned. Mulugeta was from the Ethiopian Public Health Institute. And it was very interesting to frame entomological activity, but through a public health optic. And I think that's a very interesting foundation in terms of moving towards the community and bringing them in, even though you've put some of the issues that you're facing in terms of these hard to reach communities, the education and awareness around the disease seems to be picking up. I'm sure that would be a very interesting evolution.